Welcome to the DRIP podcast, hosted by myself, Angela Craig. I am an advanced practice nurse, a clinical nurse specialist, and a senior medical manager with medical affairs at Baxter. DRIP standing for D, define, R, research, I, innovate, and P, practice. It embodies a patient-centered, evidence-based approach for cutting-edge medical science. Our mission is to foster scientific discussions with the brightest minds in emergency and critical care, with a never-ending ambition to save and sustain lives. Join us as we navigate through topics like fluid management, fluid choice, and shock resuscitation. This podcast is part of a non-promotional education series. Our guest has been compensated for their time and participation today.
Hello and welcome to the DRIP podcast. Today's guest is a distinguished professor of critical care medicine, bioengineering in clinical and translational science, and holds an endowed chair in critical care research from the University of Pittsburgh. He is currently on leave and serving as the Chief Medical Officer for Spectrum Medical, a late-stage medical device company developing diagnostics and therapeutics for sepsis. Dr. Kellum received his medical degree from the Medical College of Ohio in 1988. His postgraduate training includes an internship and residency in internal medicine at the University of Rochester, New York, and a fellowship in critical care medicine at the University of Pittsburgh. He's authored more than 750 publications and has won several awards for teaching. Please welcome Dr. John A. Kellum.
Hello, everyone. This is going to be a great podcast today. I am your host, Angela Craig. I am a senior medical manager with Baxter Medical Affairs, and we are going to discuss today more about fluid management. And we have Dr. Kellum with us in the house. Woohoo! Welcome, Dr. Kellum. I know the introduction shared your bio, but maybe just share with us what's something that's exciting in your world today.
Sure. So I would say in a word or two words maybe, precision medicine. We've talked about precision medicine for quite some time in critical illness, but it's really only been the last few years that we've started to actually see precision medicine trials. So that to me is really pretty exciting.
Yeah, it really is. And you are definitely, we are seeing more in the literature about precision medicine and precision fluid management. And that's really what we're going to talk about today. So I love that. We thank you for sharing with us today. And so much of your career has been in fluid management. And so we really want to just hear about some of your work in fluid management. And I think what would be nice is to start off with just discussing the ROSE principle in fluid management. R is rescue, O is optimization, S stabilization, and E for de-escalation. We'll start with rescue. What do you think is really the main objective with this phase of fluid management?
So I think it's great to focus on rows. I think it gives I think a structure to how we think about the different phases of fluid management, and it is sort of enables precision medicine at each of the stages. And so let's sort of walk through them. So I think in rescue, it's exactly what it sounds like, right?
Mhm.
The patient is really at grave risk of death or serious organ injury, and resuscitation is critical. Minutes count in this stage. This is not a stage, and this is critically important. This is not a stage where most patients actually go through. If all of your patients need to be continuously rescued in the ICU, you're obviously not doing something right. Most patients actually start at the optimization phase, which we'll talk about in a minute, but you need to be able to recognize rescue. If you don't recognize it, you'll be too slow in your response. It's also a stage where we don't have a lot of opportunity for precision medicine, but there are some things where we can be precise. So you can identify the classic signs of shock. That's how you identify someone needs to be rescued. This is hypotension, confusion, often but not always, tachycardia and tachypnea. Patients have cold and mottled skin, something we call livedo reticularis, and they have delayed capillary refill. When you see this sort of thing in the right clinical context, not that you've been out shoveling snow here in Pittsburgh, perhaps, but in the right clinical context, this is someone who you really need to rescue, and that can't wait. But you still can be thoughtful in terms of what kind and how much fluid, right? Giving liters of saline to patients who are bleeding is not a good idea, and the same can be said giving lots of saline to patients with acidosis. Now, I'm not suggesting you can sit on your hands and wait for an H&H, right, or Chem 7, but you can use the best information you have available and sort of move from there.
So I like how you're alluding to fluid type. When we think about saline, I think so often we call it normal saline, but the reality is it's acidic, right? And large amounts of saline can actually cause lots of challenges in patients. Can you just speak to that?
Yeah, it's got a very, abnormal, composition, right? It's normal in the chemical constraint of the concentration of point 0.9 normal, 0.9% saline is close to isotonic, but it's not normal in terms of chemistry, right? So it has too much sodium and a lot more chloride, and it's that excess chloride that leads to metabolic acidosis. And although we can discuss the impact on things like mortality and acute kidney injury, and a lot of it depends on the dose and how critically ill the patients are in terms of what kind of signal you see. There's no discussion about whether it produces metabolic acidosis. It does, and in those circumstances where that's important, which is often the case in the ICU, we want to be careful with that fluid.
Yeah, very, very well said. And so let's think about O for optimization. When I think of optimization, I think of back in the day when we used to say, hey, let's just constantly give fluid until the patient is no longer fluid responsive and get them to the top of their Frank Starling curve. And really, what I'm hearing now and reading about is that it's not really about getting them to the top of their curve, right? We want them to be perfusing and we don't want them to be hypotensive, but we may not need to continually give them so much fluid to where they're no longer responsive. Back in the day, that's how we trained. And I think we've learned a lot from that. And before I let you speak to that, because I'm really anxious to hear your thoughts about that, I want to just share when I say fluid responsive, that's different than fluid management, that's different than fluid balance, right? So when we talk about a patient who is fluid responsive, we are talking about somebody who increases their stroke volume by 10% or greater with the fluid bolus. So whether that's a passive leg raise or whether that is a fluid bolus that we're giving rapidly, a small fluid bolus to assess that, that is a 10% or greater increase in stroke volume or stroke volume index. So that's very different than just if they're than their fluid balance, right? So tell us what you feel like is important in that optimization phase of Rose.
Yeah, so thank you for that background. So that saves us the trouble of explaining what fluid responsiveness is, and I agree with your definition. Optimization, I think, is really the point at which, and I have to say, most of our trials deal with optimization. Right, rescue is actually very difficult to study, and most of the literature is really around actively bleeding patients with hemorrhagic shock, and not really patients with sepsis. Those patients, for example, are really more in your optimization phase. If you read the recent trials, you'll see that they're always, we've given a few liters of volume already, and then we're now in a phase of titration. So this is a point where we're really deploying precision medicine, right? And the biomarker that we're using for this is exactly what you're describing: fluid responsiveness. The hemodynamic measures is the biomarker, if you will, that's allowing us to provide precision medicine at the bedside to these patients. And I think, and I certainly trained in the world that you described, right, where we would err on the side of too much fluid. because we were worried about not giving enough fluid. So we wanted to resuscitate until we were absolutely sure the patient wouldn't benefit from any more fluid. And I think the right answer is you shouldn't err at all if you don't have to. And getting more precise and using this biomarker of fluid responsiveness is one way to do that. There was a recent meta-analysis you may have seen by Wang et al. In Critical Care Explorations, which really looked at this. There have been 9 RCTs, I think about 700 patients in which passive leg raise primarily. There were some other techniques used, but dynamic measures of fluid responsiveness were used, and there was a reduction in mortality, or at least improvement in survival, and a reduction in acute kidney injury in these trials. So this is a meta-analysis where you pool a bunch of studies together. I think many people would consider that to be hypothesis generating, but the data are pretty compelling. And if you want another piece of compelling evidence, I would point you to, and it's obviously I'm the senior author on the paper, so I'm quite biased, but I think it's an excellent example of precision medicine in cardiac surgery, and that's the Big Pac 2 trial that was just published in Lancet, and that used a biomarker to identify high-risk patients for AKI, because giving this optimization technique to patients that are really low risk for AKI, if AKI is your endpoint, is not going to demonstrate benefit. And this trial basically used a bundle of therapies in the KDIGO guideline to manage these patients. But the one that mattered most was advanced hemodynamic monitoring. And so preload responsiveness was used, and there was a substantial reduction in the rate of acute kidney injury in that setting. And I think that might surprise some of your listeners. Some of your listeners may wonder why giving less fluid in some cases. And remember, the point of this is really not to give less fluid. It's to give the exact right amount of fluid to patients,
Exactly.
right? Some patients would get too much. Some patients would get too little if you just picked a number. And so rather than just picking a number and providing it to everyone, this is individualizing in a precision medicine sort of approach the right amount of fluid to give to these patients. And so why would that benefit? Obviously, giving enough fluid would benefit patients' kidneys, but actually avoiding overloading patients,
Absolutely.
causing congestion in those kidneys. Remember, the kidney's a capsule, it can't swell.
Mm.
So you're going to hurt patients' kidneys if you give too much volume. And right sizing the fluid resuscitation is where hemodynamic monitoring and fluid responsiveness really come into play.
Yeah, that's excellent. And when we think about this, no longer is it that you have to have a Swan catheter in place or a PA catheter in place. You no longer have to have every obviously, I don't want to diss a PA catheter. That's very important for what it's needed for. But we can actually monitor quite a few things non-invasively. And we can get stroke volume now, stroke volume index non-invasively to where we can utilize this without an invasive catheter. I think that's what the point I was trying to make. Everything has its place when you need it, but the ability to do this, maybe not even in an ICU, you could definitely, but maybe outside of the ICU where we can actually do more precision medicine. I love that. Well, let's move on to we just did optimization, and let's talk about the stabilization phase. Explain what we do then.
Yeah, sure. So this is the stage where you're sort of fully resuscitated, but
Mhm.
you're not quite ready to start removing fluid, right? This is the first time that you're really sort of converting to thinking more in terms of a shift or even a 24-hour period, as opposed to hour by hour or even minute to minute, right? This is the stage where you're actually saying things like, well, what is the input and output balance for this patient? When you're in optimization, or you're rescuing a patient, you're not paying attention to the eyes and O's, right? This is not about that. But now in the stabilization phase, you really want to start looking at a more long term in the sense of days as opposed to hours or even minutes, sort of management profile. And for that, you really need to start thinking about fluid balance.
Yes, for sure. So then, to our E, de-escalation. And I know this is an area that's near and dear to your heart as well. You've worked in the renal world a lot as well. For some reason, I always think about the renal patients when we're pulling off fluid, but it's not just renal patients. But tell us a little bit about de-escalation.
Sure, sure. So other words for this stage are de-resuscitation, which I don't really like the sound because it sounds like you're putting the patient back in shock, which is
Yeah.
obviously not the point, or evacuation, which is also isn't really quite right. But this is the stage where you really sort of need to either allow the patient to autodiurese, and a lot of patients will, and you don't need to provide, any sort of help to those patients, but many patients obviously will require either chemical, meaning diuretics, or mechanical fluid removal, meaning renal replacement therapy. And so I think here you also need to practice precision medicine. And I have to say,
Mhm.
if there's one major criticism of where we are today, I think we've made a lot of progress in this whole field. But if
Mhm.
major criticism about where we are today is we really haven't quite caught up in terms of applying the precision medicine to the de-escalation phase, to the E of the rose sort of paradigm. We're just not quite there yet, and I think this plays in terms of things like timing of your diuresis and
Mhm.
timing of your renal replacement therapy. This concept of early versus late. That's not precision medicine. That's a one size fits all. And the other point that precision medicine is really is the volume of removal. Like how much fluid do I remove over a given period of time? And for that, I really do need a very similar kind of approach than what I would take with the other stages of Rose.
And, when I think about, questions that I get when I'm out in the field or at the hospital that I work at, sometimes they'll ask, "Hey, can we use non-invasive hemodynamic monitoring to help us as we are de-escalating or de-resuscitating with CRRT, or even when we're giving IV diuretics to help pull fluid off?" What are your thoughts about how maybe utilizing stroke volume may be helpful with a patient on CRT or someone who is getting IV diuretics?
Absolutely, and it's really the non-invasiveness that has allowed this. I mean, to the idea of putting in, invasive hemodynamic monitoring in a patient that you're now trying to de-intensify, and I think this largely the fact that we had this deficiency in the
Mhm.
technology until very recently. It hasn't been that recent, but I mean,
Yeah.
sort of 20 years ago, we really didn't have an option. The only non-invasive, technique we really had was to bring an echo into the machine, and back in those days, we didn't really have point of care ultrasound. We really had to call, cardiology to come do an echo at the bedside, and that just wasn't practical for sort of guiding fluid removal. So as I'm removing art lines and removing central lines, the idea that I have a non-invasive way of
Mhm.
really looking at this is particularly good application of this technology. Now, I think I would be remiss if I didn't comment on another aspect of monitoring. So can I say something about Foley catheters?
Oh, sure. Absolutely.
I think urine output is also a biomarker, right? And there is
Yes.
sort of misguided, and it really is misguided emphasis on the potential harm of Foley catheters without potential benefit. And I think, putting in a Foley catheter and not measuring urine output is absurd and wrong, and we should definitely move away from that. But the idea that a patient who you really are resuscitating or de-resuscitating, and not having any way to guide that therapy when you have a biomarker, which is
Yeah.
for an output readily available, is really quite odd. Have evidence to suggest that tight monitoring of eyes and nose with recording the urine output every couple of hours improves outcome. Now that's an observational study, so it's associated
Mm.
with an improvement. And we also have automated systems for
Yes.
measuring urine output, which are definitely more accurate than just bedside, nurses. Bedside nurses are busy caring for patients. They
Yes.
have a stopwatch and measure the urine output every hour and record it. That's difficult. So urine output is also a biomarker
Yes.
and also very important to include.
Yeah, I agree. It's so important, and the accurate documentation of that to where we can really keep track of that. One of the nurses that I work with mentioned that they had a patient on CRT, and they also had the patient on non-invasive hemodynamic monitoring. And what they noticed was as they were pulling fluid, as they started to see that downward trend of the stroke volume, when it started to get a little bit too low, they knew to kind of back off on the pull so that they could basically kind of re get more stabilized, and then they could alter it. And I thought that was very creative, and I thought that makes total sense. What are your thoughts about that?
No, absolutely. In fact, if you think about sort of what we could be doing much better,
Mhm.
the management of fluid removal with renal replacement therapy, diuretics also, but when we treat with diuretics, we don't give a diuretic typically. We can use an infusion of diuretic and monitor that, but in general, we're using bolus therapy with diuretics, and once the diuretic is in, we're not so much titrating that diuretic every hour. Whereas when we're removing fluid with CRT, what we're essentially doing is usually the exact opposite of what we should be doing. So what happens is that you have a lot of excess volume in the patient, and that volume is in the vascular space and it's in the extravascular space, right? My only access to removing that fluid is the fluid that's in the intravascular space. And obviously, that's not liters and liters, right? I mean, if you have a 5 liter plasma volume, maybe you're up 10%, maybe you're up 15%. Well, that's only, 600 cc's. Once I pull that out off of the patient, I've removed all of the addressable fluid, and now I have to wait for vascular refill, right? And until that vascular refill happens, then I don't have access to any more fluid removal. So our typical response is that we start low and then we work our way up if the patient is tolerating this. And I'll see people, starting at 50 cc's and going 75 and then 100 cc's an hour. And then if they're tolerating that, they're going up to 200 cc's an hour. By the time you get there, you've practically removed all the fluid that you safely can remove. And now the patient is on a rate of fluid removal that is totally inappropriate for someone who doesn't have any more fluid in their intravascular space. Their vascular refill rate is much, much slower than that. And I'm going to have to wait for that before. So in fact, you really should be titrating up very quickly and then titrating down as the patient is stabilizing in terms of that input output balance. We have data to suggest that if you remove a net ultrafiltration rate in excess of about 1.75 mLs per kilogram per hour, which isn't that much, that's actually associated with harm. And it makes sense, right? Because if you maintain that amount of fluid in a patient, removal of that amount of fluid in a patient, you are going to jeopardize their intravascular volume because it's faster than their vascular refill. There's an interesting study, and I can't quite remember the authors, but it was in a journal that I'm sure most of our listeners listen to, which is a journal called Mathematical Biosciences. No, I'm being glib there, but that paper back in 2018 looked at mathematical models of vascular refill and showed that patients that are critically ill with high amounts of inflammation and capillary leak actually have a very, very slow vascular refill. So your dialysis patient in the dialysis unit, that's slow enough, but you're in the ICU, that's a horribly slow vascular refill, and that's where patients get harmed by removing fluid too quickly.
Yeah, very good points. Very good points. And I think just being a little more scientific in our removal, looking at how the patient is doing overall with their stroke volume index, looking at their cardiac output index, how are we affecting them? You bring up some excellent points, very excellent points. So as we think about in the totality of the Rose principles, do you feel like there's one area you've kind of alluded to them all? Do you feel like there's one area that we really should focus on to get better?
Yeah, so I do think we're bad at all of them quite frankly. But I think
Oh,
the last one, I think the E, stage, the de-escalation phase, is probably our worst. And I think a lot of it is because of exactly the reasons that we described, right? That applying invasive hemodynamic monitor, which is really all we had several years ago, is really difficult in this stage because you're de-intensifying the patient, which is why I think the non-invasive hemodynamic monitoring approaches that have developed in recent years is really quite appropriate for this particular phase. And the example that I gave with fluid removal, with dialysis, with renal replacement therapy, is particularly a strong example of where we often get it wrong. So I think that's I think we've gotten better in optimization. I think there are a lot of and that meta-analysis that I mentioned is a good example. I think we've gotten better. We're still doing studies though, where
Right.
we're talking about just giving a fixed amount of volume to patients and more or less, and that's not really going to be useful. We're going to have to guide it with a more precision medicine approach.
For sure, for sure. Well, we want to thank you so much for all you are doing and all you have done for helping patients and their providers with your knowledge, your research. Hey, you guys, all you have to do is just Google Dr. Kellum and you will see the amount of research and expertise that he has in this area. And, someone may want to reach out to you if they have questions, Dr. Kellum. How would you like them to maybe reach out to you or reach out to me and I can reach out to you? How could they
No, no,
best
no, it's
reach out
fine.
to
I
you?
mean, my email's really easy to remember. It's just my last name, Kellum at pitt.edu. And so people email me quite regularly. I don't mind it at all. So please, if anyone has questions or comments, feel free to reach out.
Awesome. So it's Kellum
Exactly.
at
At pitt.edu. PIT. Yeah, yeah,
pitt.edu. And Pitt is with one T, correct?
two T's.
Two T's.
Yeah. Yeah,
So
The Pit, right? So we're all familiar with that movie now,
yes.
that television.
Yes.
So,
For
yeah,
sure. Well, thank you again for your great wealth of knowledge on this topic. We really do appreciate it. And I hope everyone stays warm and has an amazing rest of your day today.
thank you, Angela. Great talking to you.
As we conclude today's episode, I remind our esteemed medical colleagues that the opinions expressed herein are solely intended for professional discussion and should not be construed as medical advice. We encourage all listeners to consult their own healthcare providers for personalized medical guidance.